truly an honor and it's a pleasure. It's more of an honor for me to call Dr. Chang a personal friend, but as when he's not saving the lives of children as a cardiac um, surgeon, he is focused heavily on artificial intelligence in the clinical setting in healthcare. In fact, he is the CEO of a very large group called AI Med, where that's all they focus on. So with that, I'm going to hand it over to Dr. Chang, and there you go.
Of course, Gary, I will call you a friend. So I'm really have to bring my A game today because not only is Gary having me fly in from a busy schedule, but I have met a few people earlier that say they came just to hear what I have to say. So no pressure there. And Gary asked me to say a few wise words, and I was telling Greg, my good friend from Lilly, that I'm actually I don't have any wise things to say about it. What I do is repeat things that other sectors have said and bring it back into healthcare and AI. And I think perhaps there's a takeaway there. Just, for those of you who spend most of your time in the tech area, AI area, or the clinical world, spend some time in the other worlds that are just emerging in terms of new ideas all the time. So here are a few thoughts. I just flew in late last week from China after I gave a couple of talks there. They asked me to talk about what I think is happening now and what's going to happen in the future. So I was telling Greg also, I've been in AI for about 40 years now, including years of research in AI in healthcare. Back in the days when I say I do research in AI in healthcare, people literally didn't know what that was. Like, what does that mean? Well, I was looking at signals in biomedical noise in the ICU setting. And for those of you who are math nerds, it's things like chaos theory. So back when we had virtually no compute power, I was the compute power. I had to manually plot everything. And then there was very little data. And so this is really the golden era of clinical medicine. I'm also the proud mentor for about 100 young people that are interested in going into healthcare every summer. And I always tell them the best 25 years in healthcare and medicine are here, starting here and now. So we're very, very lucky to be in that era for sure. I'm just glad I'll be around for a few years longer, seeing all of this happen. After having waited, if you can imagine, waiting 40 years for AI to surface, and it's finally here, so it's a very exciting time for me. And if you sense a certain passion or dedication, it's because I waited for so long for all of this to happen. So here are a few insights from the talks I gave in China. It's funny because when China invites me, Shanghai, to talk about the current era and the future of AI, I learn just as much when I'm there from what they have to talk about and what they have to say. So one really good tip here is to travel and see what other countries are doing with AI. You learn a lot more than you might think here. So as one of my mentors say, the US is not the epicenter of the universe, so try to travel a little bit. So what I talked about was, from the days that I was in school at Stanford, probably from 2010 to 2014, and up until a year ago or so, was sort of the best time for what I call computational intelligence. So, deep learning for sure, and I do a lot of work with deep learning, but that is computational intelligence. The humans, or especially clinicians, were kind of a little bit left out of that landscape. So now with generative AI and what's happening, and I remember telling Gary 2 years ago, generative AI and LLM is probably the best gift that Kore.ai could possibly get. It's like ahead of schedule in a big way. So it's really huge for companies like Kore.ai that deals with language. So now we're in the generative AI, and I know probably everyone here is familiar with that term, but if you're not, it's basically taking what's available and synthesizing something that serves a purpose. And I think generative AI, I think we're still in healthcare probably using 5% or less of what it's capable of doing. So in other words, I think there's a lot more to be done, a lot more coming. It's getting more sophisticated by the month, it seems like. And I use someone asked me in China, do you use actually a large language model in your practice? And I said I use it every hour. For those of you, you're all invited to come see patients with me in my clinic. As a matter of fact, I'm seeing patients tomorrow. I use it for multiple purposes, from authoring a letter for justifying a test for one of my patients, to helping to make a diagnosis that might be elusive. So I really take advantage of what's available now. And someone asked me a good question, which is, what do I consider LLMs like ChatGPT and GPT-4? Is it information or is it knowledge? I think it's I think it should be called super information. We've never had information at this level with this availability ever before in the world, and also in the world of medicine. So it's extremely helpful for physicians. But guess what percent of physicians actually use a large language model in their practice, even though GPT has been around for 2.5 years now? Close to zero. Yeah. It's not uncommon that I'm in a big group of clinicians and I'll ask the question, how many are using LLM in their practice? And one or two hands will go up. So you're correct. It's probably in the single digits for sure. So why is that? So I think it's for the clinician. How many do we have clinicians in here? Usually not too many. Any clinician. Okay, so I'm the only person. So I can tell you from the clinician's perspective, the takeaway should be, first of all, they're very excited about what's happening. They don't know exactly why, but they're very excited. They see the possibilities just from the social media and the news. They don't know what quite to do with it yet. So part of your jobs here as non-clinicians is to spend a few minutes and talk about this with your clinician friends and colleagues. They're eager to learn. I chair also a monthly course for clinicians to learn about AI in healthcare. And we've graduated now close to 2,000 clinicians in the last couple of years. So, and the interest level is not just in terms of volume of people that come to these courses, it's also the diversity. I'm seeing clinicians of all kinds coming, including nurses and pharmacists. So it's really exciting that it's captured the attention of the healthcare profession. They do need to take a breath, as I say. I feel like they're kind of teenagers behind the wheel of a car for the first time. They want to go fast, they want to go far, but they need to just take a breath and sit down with some of you and learn about AI and what large language model is. Very few will know what a RAG is, so you need to really be patient with them. And they're smart people usually, so they just need to learn from you what to do with this amazing resource. So I think we're only about the 5% mark, the tip of the iceberg, in terms of what generative AI can do for healthcare. And then I talked about the future of healthcare. So I think this era for the 5-10 years that's coming up is what I call convolutional intelligence, the combination of what AI can do and what humans can do. A lot of what's going to make generative AI better is the human feedback. And that's always underemphasized. If you look carefully at GPT-4, even GPT-4 has the reinforcement learning, which is a way too sophisticated term for basically a thumbs up or down. I think we can do so much better, and I'm glad that you guys are thinking of that at Kore, is to do better than a thumbs up or down. There's so much human knowledge and wisdom that's not going to be captured if you just go to a simple thumbs up or down. So try to focus on the reinforcement layer for these tools as much as possible. What's coming up 5 years from now, just give you a little crystal ball to see what's coming, is what I will call the cognitive intelligence era for the following 10 to 20 years, where humans are going to be back in the game, particularly clinicians, of deciding how AI can best help us, which is really great because that's what we need, is sort of this transdisciplinary approach to AI in healthcare, where everyone is involved, everyone will be learning from each other. There's, as you know, a huge disconnect between the clinicians and the non-clinicians right now in AI in healthcare. And people like Gary and I work closely because we want to narrow that gap. So for the clinicians who are not here, take a breath, learn about AI. Don't be over-eager either, because then we'll get in trouble. For those of you who are not clinicians, I say look up. By that I mean When I walked around today, everyone's looking at their laptop or their cell phone. Okay, so you need to look up and spend some time with clinicians. And what I recommend usually for the data scientists that I talk to a lot is spend 5 to 10% of your time actively involved with a clinician in their natural habitat. Go to clinic, go to the operating room, go on rounds in the hospital. You learn so much more than talking to each other all the time about what's best for healthcare. There's a reason why when they did a review of 400 plus papers on COVID and AI, 400 papers, guess how many were actually in practice or actually fulfill the needs of the clinicians? Out of 400 plus papers on imaging, on decision support, 400 papers from elite places. I'm not talking about just publications from MIT, from Harvard, from Stanford. Guess how many were in practice? You can stick with your answer. It's not near zero, it's zero. 0 out of 400 and some papers were actually adopted for practice and or the clinicians found to be even relevant, never mind impactful. So I'm greedy. I want at least half in the future papers to be not just clinically relevant, but impactful. So right now I'm privileged to be working with 3 senior PhDs in data science, very capable, and they're not really going to get approval from me to do a project unless they have a clinician co-champion for that project. Ideally, an idea that's engendered in the clinic setting on rounds is where I'm going to be very excited about that project. And they actually think initially they weren't sure about that kind of clinician oversight or influence, but now they're convinced they're having more fun with the projects because they actually have something that will be not just published. You can have it both ways. I'm not saying that you should do something only if it's going to be adopted for practice. I'm saying get it published and put it into practice, which is the best of both worlds. You don't have to choose one versus the other. And that's sometimes a misconception. If I do something that's practical, it may not be publishable. The barrier to entry to publish on AI in healthcare across journals, even the best journals, are so low right now that you're likely to get just about anything published right now. So don't worry about getting published as your main hesitation to do something that's more practical. They're all publishable. All right, so in essence, takeaways here, think about getting clinicians more involved in whatever you're doing. They are actually very eager to learn right now from people like you. And also, spend some time with them. And just as clinicians should spend time with you. And lastly, think about human elements more and more as we move forward. I'm not saying this is the end of deep learning. So I know sometimes my quotes get out there in the media. Please don't say Dr. Chang thinks deep learning is done, because my mentors at Stanford will not talk to me. I love deep learning. I did a lot of work with deep learning. I think it really awaken the imagination of people that are involved in health AI. It really raised the possibilities, but I think it was computational. Now that we have, I think, the opportunity to get not just humans, but clinicians back in the game, I can't wait for the next 25 years in terms of what AI can do in healthcare. So with that, I'm happy to answer a few questions that you might have. Hopefully I didn't say something that was too controversial to be quoted, but I do think I want to raise one thing that John reminded me from last year, which is I often get asked, what about the ethics of AI? And what about regulatory issues with AI? And I think we ought to balance the discussion with what happens if we overregulate AI in healthcare? And what are the ethics of not deploying AI? I think the pandemic has shown us that we were caught with really a lot of weaknesses in the health system because we didn't have the data and the IT infrastructure where it should be, and we definitely didn't have AI ready for anything. So hopefully that will change when we get the next pandemic, which I think will be here in the next decade or so. So we really, really need to. This is like our sort of in between pandemic period that hopefully we're not going to waste the lessons learned from the COVID pandemic. Any questions? Yeah. Sure. And go right to the talks? Okay. So we'll save the questions to the end. But think about these themes I've outlined as we hear from our outstanding speakers. All right? So I think Greg is up first. So the questions to you, Greg, would be, and you can reframe them, is what are lessons learned for you? So the theme is lessons learned from the real world in real time. And because I think you have some really good ones. And then what do you think is the future of what you'll be talking about?
So, quick introduction for the group. I'm a vice president of the Florida Blue Service Center for Blue Cross Blue Shield of Florida. And so we've been going down quite a long journey of leveraging all various forms of AI, especially in partnership with Kore as we look at their conversational AI tools, specifically both voice and chat. And one of the risks in what we've been talking about, and you hit on the human aspect, is the voice of the employee and how do the employees feel as we go through this. And the feedback I get, especially from our frontline individuals, is we're going through these large AI initiatives and you're having that conversation with a large audience. Well, their first thought is, well, you're going to replace me, right? And what does that look like? And so as we try to build the trust, and I think that's a theme that you'll hear in my conversation, the trust with the employees is, well, what's next? And it actually opens up those opportunities for them to develop themselves and do some of the work that you were stating, which is oversee what the models do, make sure you're doing the prompt engineering, actually understanding what the outcomes are, and they can see it as a way to develop themselves. And that has helped. And again, I think that's going to be one of the biggest hurdles for any large organization is how do you bring your employees along in the change, in the journey, which again, as we start down this path, because we're going to move into leveraging agent assist next, which we're excited about. And the way we frame that for our organization is, especially those of you that are in customer service, especially in healthcare, right? Because a lot of your customers are at a time of need and a time of stress. And what you need those agents to do is be confident in their answers. As soon as they appear unconfident or not confident, they possess that back into that individual that's talking to them. And what we're excited about with this new technologies and the way we frame it for our employees is just think of a world where you're not searching around for information, you're not looking through all these multiple knowledge articles, but it's going to be prompted to you in the context in which that member has called in, right? And I think we even saw in the demo too, as you saw some of the changes in the prompted responses. That's what we're excited about, and that's how we frame it to our employees. Because that word of trust is the most important piece for our organization. We are helping communities and people achieve better health. And if you think about on the customer service side and what do these AI tools do, well, it helps us drive that level of trust with our customers, regardless if it's in our digital channels, whether it's through our customer service or even in our retail setting. We're trying to build that ecosystem so you get the same answer the same way, the same time, which then leaves that level of trust. And I'll conclude with this as we go back and forth. One of the things that we've started to do is implement new, more integrated service and care models. And so we want the clinicians, even though I know there's none here, to operate what we say at the top of their license, right? Take that work away from them, and how do you empower that frontline staff that might not be clinicians to have some of those simple conversations so that we can actually focus the interactions more at care-based and not at defects, right? So most people call into customer service because something went wrong. Our ideal world is you're calling us because we are your health solutions partner. We are helping you achieve those outcomes. So that's our ideal state, and a lot of the work that we're doing is building towards that North Star.
Wow, I can really resonate with what you're saying. I think if I were to look at my day-to-day in clinical practice, I would say 20, 30, 40% of the time, I wish something else was doing that, or someone else, not someone else, something else, in this case, was doing that and not a human. So it's definitely going to, I think, relieve a lot of the burden. As you know, a third to or more of the clinicians are thinking about leaving healthcare in the next 5 years. That's very sobering. And then on top of that, we've had more students applying to medical schools than ever before, but a third of them now are already depressed about going to medicine because of what they're hearing in the hospital. So it's definitely the best time to relieve that burden any way you can. So I think, again, I love what you said about just making sure this is upskilling everyone. And there's a common saying that AI at its fullest is going to replace 20% of the work for the typical worker and so replace 20% of the work for 80% of the workers, and replace 80% of the work for 20% of the workers. So your job is to make sure that you're not in that 20% where most of your work will be taken over by automation or some sort of intelligent agent. So, and it's not that hard, just learn about AI and how to upgrade your job and what you're doing. When ATMs came to the banking industry, some of us old enough to remember, it didn't replace tellers. The number of branch offices and number of people working in finance actually went up because people figured out a way to work with it rather than think that it's a threat. So Manan, you do a lot of work also in the patient experience area, I learned when I looked you up. So tell us how, in the real world, in real time, how AI has been impacting that area of what you do. You're in the interface between computer science and business, you said to me. So what are your lessons learned, and where do you think we're headed in the future?
Hello everyone, Manan Mohale, VP at Care First. I lead the technology and innovation team. So thank you firstly, Dr. Chang, for having us part of the panel, appreciate it. So our journey actually started in 2016 when we started building our customer experience platform. And this was the era where CRMs were big. And one of the challenges for us was our customer service reps were looking up 8 systems to go in and service a member. So you can think about how tedious that is too. So we started building our member engagement service, our customer service platform, and that escalated. And then that was manually configuration were done to the systems. On one platform, we could have customer service get all the information that needed. And so that took care of our associates as they were helping our customers. One of the challenges in the space we are in, the federal space, is our customers are a bit different. So in federal space, as you can imagine, in DC and Maryland, they can pick up the phone and call the congressman pretty easily. So we have to give them the tools that they need and meet them where they want to be met. What that means is with our implementation with Kore.ai, one of the tenets has been, if they want to talk to a customer service rep, all they got to do is just say customer service and they get someone. But AI is powerful for folks who are in a rush. They need the information. It gives you the exact same information that a human would provide. So that has been a tenet as we've gone through this journey. It has been a long journey for us, but it has exponentially grown in the AI space, just providing information to our members to what they need. For folks who want to talk to someone, just be able to talk to someone, provide them that information. So that has been a lesson learned for us for sure. We have also taken in a human in the loop approach. And one of the things we did when we installed our AI was, so say a member decides to talk to a human. One of the metrics that we want to measure ourselves on is what was the reason, right? And very meticulously understand why did they ask to talk to a human, so we could improve ourselves and put that back into making it better for the information that they're gonna get. So for us, it's a journey, right? I don't think it's gonna be solved in 1 day or 2 days, or we don't wanna, like some of the airlines who just decided to shut off their customer service altogether at the end of the last year. We are not in that business. We are in a business of providing excellent service for our member side and meet them where they wanna be met. And on our provider side, then, to your point, it's a different journey, right? It's different audience. Providers need much more different information on what they need information that they need. A lot of times there's volume, and we want to provide them. I was talking to Mike about, and he's going to be talking about his awesome implementation, but bots talking to bots. That's an excellent, I believe, implementation in that space. So tons to do, but I think this is, as you were saying, there's a lot of possibilities and a lot of learning from each other.
Great, thank you. Again, I also resonate with what you're saying, and I think, we're in a new era of cohabiting with our AI, and we're not used to that. We're used to a certain human paradigm, and then there's AI, and we need to. That's why I call this the convolutional period. A third function is going to come from combining these two. I'll give you an example. During lunch break, I took 15 minutes, as Gary knows. I had about 10 texts from different patients. And I am one of those unusual doctors. I feel like I need to give everyone access with my cell phone in case they need to get a hold of me. So most of them were probably questions that could have been taken care of with a smart agent, knowing that I have ability to curate those answers. And I think that's what my patients and families want from me, is I'm still in the loop, but it's not me that's doing 100% of the response. Because some of the responses, I'll admit, are very short. I try to have a personal rule that at least 7 words, and not like a yes after, some of these patients and families, you can imagine, and I think, have like basically 4 or 5 screens of a message. And I just feel like it's a little bit rude to say yes or no, and when it ends with a question. So I try to have a sizable response, but the problem is that I don't have time sometimes to have a expedient reply, and it would be nice to couple myself with an agent or a conversational agent that has my thinking process that can answer a basic question back. So they have the best of both worlds, and I'll have the best of both worlds. But we have to redefine a lot of words and concepts. What is communicating? What is thinking? What is learning? We have to redefine these words in the era of AI, and we're not used to that. I think the sooner we have clear definitions of these concepts, the better off we're going to be in terms of leveraging AI for what it's supposed to do. So then our last panelist, Mike or Duke, whatever you prefer, right? So is going to tell us about himself and what he's doing with AI and lessons learned there too.
Thank you for that. Actually, it's Duke. It's easier to remember. It's like a dog. So I'm a consultant by trade. I'm a partner with Guidehouse. We do a lot of provider work, so I appreciate getting put in between the two payers. It's kind of where I'm at every day. But one of the things I'd like to do real quick, from how many people are in the audience are actually in healthcare in some capacity, one way or another? On the payer side, provider side? All right, a couple. So the thing that's more interesting to me, quite honestly, and I'm very contrary and I'm very direct, and Gary's over there saying, Jesus, I hope he doesn't say something. But I'm more interested in the conversation, not the AI. I think the AI will spin itself up the way it needs to, but the thing that we're using Kore for is outbound conversations. And what's the purpose of human communication? It's either to exchange stories and knowledge or to exchange information. And we need to get information back from the payer side. So we have to have bots that can carry on an intelligent but actually constructed conversation. In our case, or the work that I do is predominantly around the revenue cycle. So I'm trying to either mitigate loss through denial prevention or maximize collections through the follow-up and those things. There's a bunch of others. We're doing some cool things with clinician in-baskets where we want to assimilate the information from the in-basket where it's not a clinical response. Maybe I'd like to reschedule or do something, one of those things, kick an outbound call. But for the things that we're building right now live with our clients, it's more about, I said it earlier when I was having a conversation, it's more about small language model for me. I need to be able to, in the course of a conversation, have a bot interact with a human being much like I would. And so there has to be nuances and variation to the conversation. So instead of saying thank you every time, it should say I appreciate that. It should have some nuance to the conversation, and leveraging language models to do that, but make them small enough so there's not things like latency and all those things. If I don't need 10,000 words to carry on the conversations, I need about 10. And so it's kind of packaging those up, but it's all with the intent of gathering information so that I can automate on the back end and do something with that. And then building those conversations has become, when we first started, I thought, okay, it's going to take a couple months. And what we found is on the outbound side, it's a little more complex. If I'm calling in for a schedule, you can ask, okay, what's your symptoms and those type things. But when you're on the outbound and a rep doesn't answer quite like you had expected it to, which it seems to be every call, every question, then you've got to learn on that pretty fast. And it's not something that you can just kick out to a necessary an LLM and always have the answer. And so um, that's been the interesting part for me is replicating, using AI, but replicating human conversation with a real human voice so that a rep doesn't hang up on you. Because early in our development, we probably had maybe a third where they would say, I know your bot, I'm hanging up on you. And so it has to be something that can, so now we're doing things like, how's your day? You got, and we're trying to spin in some human interaction into that. So I think the last couple that we developed, we've actually got a thank you from the rep. This has been a great call. Thank you for calling in. So it's about the communication component for us. The AI is a vital piece of that, but it's using that to replicate a human conversation has been the challenge, and we're actually almost there. So I'm pretty proud of that.
Well, you heard from a diversity of people, and I think what I said about the worker, I think you can apply to healthcare. I think easily 20% of healthcare could be taken over. In 20% of healthcare, 80% of it could be taken over by some intelligent way of doing something. But I do think the rest of healthcare, 80% of it, probably only 20, 30, 40% can be replacing what humans do and what humans are thinking. It is complex. And if you're an engineer, you may or may not know the difference between something that's complex and complicated. There's a lot of complicated things in healthcare, but after you take that layer off, the remaining, so here's the good news. There are a lot of low-hanging fruits in healthcare. It's so fat with inefficiencies. I think most of us here agree. I used to think it's the slowest sector and the worst sector in terms of dealing with technology, second to worst. The worst is, any guesses as to worst sector in terms of adopting technology? I experienced this when my 2 girls went back to school. Education. 10 different forms, mostly the same information I had to fill out. Until 2 or 3 months ago, I had to go into the California DMV. I realized that there is now a new last place in my mind. I hope there's no one from the DMV here, but it is just so bad that it needs a total disruption, I think. But healthcare and including medical education, which I deal with a lot, are really pretty far behind. So the good news is that there's a lot of opportunities for everyone. In 20% of healthcare, 80% of the work can be displaced to something that's intelligent. But after that layer is taken off, it does get harder. So that's where I'm excited about the cognitive possibilities and the humans getting more involved, because it is complex. It's complex because humans are involved. It's not. Someone asked me a great question one time in a meeting. Why is it, and it was at the beginning of the pandemic, why is it that we can land with SpaceX, land a rocket within 10 meters of where it took off, and we can't even guess to a magnitude how many people are going to die from the pandemic? I said, because people are involved in the latter. Engineers are good about, and this is where the interface between engineers and healthcare workers have an issue, is engineers think they can engineer the problems in healthcare out of the problems, and it's not true. There are too many complexities in healthcare. It doesn't mean that engineers have no role in terms of a solution. It's just that the solutions are not going to be as straightforward as you might think. It's not an engineering problem. It's a human problem, and I think all four of us probably will agree on that. So, questions from any of you? Or I think we have an amazing, diverse panel here, so we'll be able to answer your toughest questions. Yes. Here, why don't you take the microphone so we can all hear you?
My question's around use case. All the 3 examples were more customer service, but with your experience, what kind of use cases you see around medicine or that profession with AI, right? So customer service use case, inbound or outbound, get that there is a level of complexity, but where is it going?
I actually wrote a book on that question called Intelligence-Based Medicine. So there are many uses from the clinician perspective. Medical imaging is already more than a decade old now. Most medical images can be interpreted with AI better, faster, and more accurately than groups of subspecialists in that area. Your gastroenterologist is probably considering or have already used AI during his or her endoscopic procedures. So imaging is very mature. A second area is, and we talked about it with our Eli Lilly friends, is drug discovery, vaccine design is now based on AI and deep learning. Um, Surprisingly not well publicized, but the future of drugs that are very specific to your own disease, your own genome, is within reach now, within a decade. So when you have heart failure, if you have heart failure, or if you have cancer, usually you just go on some protocol, right? And even if it's custom design, even if it's like very precision medicine, it's still not good enough. That's why so many people are still dying from heart failure and cancer. In the future, you will get your own individual drugs and therapy and timeline. So that's within a decade, easily within a decade. So that's area number two. The third area is less intellectually stimulating, but it's using robotic process automation in healthcare to replace a lot of the tedious work, like prior authorizations and revenue cycle management. That's actually more mature now than even 4 or 5 years ago. So those are three big areas that clinicians see. And then there are many, many areas. I just wrote a book on AI in cardiology. I was amazed at what's going on in cardiology already. Even though I'm in AI a lot and talk to a lot of clinicians, but there's a lot more going on. If you look at all the AI tools that are being used on the clinician side, 3/4, unfortunately, are in coronary artery disease because that's where the money is. But your cardiologist is probably using a lot of AI tools, and you may not be aware of it. So there's a good balance between clinician on the clinical side as well as the operational side in terms of deploying AI. Any comments from? Yeah.
So the thing that I would also add is that, so from a payer standpoint also, it's just not so a customer service member is just one use case, but when you look from a payer's lens, member health is probably one of the top things for us that we are concerned about. So when you get into HEDIS scores and all these scores, one of the primary job of a payer from our lens is how do we improve our members' health? So that's on the member side. How do we get them to go visit clinicians where they need to? So predictive, prescriptive, whatever we can do to help our members to get out there, and we get measured by that as a payer. So that is top for us to ensure. So that, and those applications, so AI is not new, right? This has been happening for a long time. I think the scale that it picked up, and thanks to Gen AI, I mean, that's amazing that it's in forefront. Everyone, a common person also knows about it. It's not a back end thing. Somebody is plugging in numbers. So that's a lot, as Dr. Chang was saying.
Yeah.
So you touched on prior authorizations is a big one. Any in the care management, disease management, utilization management are big, and we've made a lot of progress there. But it does anchor back on, as you eliminate some of those administrative care processes that build a level of trust with the member or the patient, then we're starting to use these models to then be prescriptive and understand, just like within HEDIS, so what condition can we predict that we can then recommend an action to go take. All that is going to work well, but again, it comes back to that word of trust is, do you trust your health insurer to then make those recommendations for clinical actions to take? So that's why I think it's important to keep actually understanding the customer's journey and understanding the trust that we build with them so they can actually act on the recommendations that come from us in line with their clinicians. That's
I also just want to add that CMS and other federal organizations have really gone a long ways and come a long ways in terms of paying for these AI services. So I'm curious to hear what all of you have to say. But it's not good to have an AI tool if it's not going to get paid, because it's just people are going to lose interest and lose funding. So now that, especially with something called NTAP, I'm sure you guys know what NTAP is, right? So it's novel technology added payment, which is going to pay for new technologies like AI. Thankfully, that came around, and more AI services and tools are being paid by NTAP than the traditional codes. So I'm curious, from your perspectives, what's the impact of AI services being available in hospitals, and how are you justifying paying for those? We'll start here and then we'll go down that way.
So for us, it's just to what Dr. Chang was saying, right? So having AI available is definitely very important for us to get that information, get ahead of the curve, and from where the members are taking care of for themselves, right? And as the investments come in, and from purely investment standpoint, we work closely with, on the federal side, we work closely with OPM, and some of these initiatives that we do actually get funded by, in Blue Cross Blue Shield, there is, in the federals, in the PPO network, there is, the association works with director's office, and going into details. But there is a innovation lab also that CMS has. So if you're working on Medicare, Medicaid side, you could work directly with CMS. I think there is a lot of innovation labs that you can submit your paper into, and for funding, if you want to try some stuff. There's also a lot of good work happening at NIH, and that also is also funding some of the grants that can be available for some of the things that you want to take forward.
I'll say from a Fed standpoint, I've actually helped a lot of clients with they're really only reimbursing about 32% of the cost, so it's something. It's not nothing, but you still got to foot that bill. Where the money actually, there's a lot of opportunity that our clients don't realize is at the state level. They know New York had a 12-month grant. I think it was funded by $1 billion, and by the deadline of the end of February, at least the last I'd read, they had issued 350,000 of that grant because nobody applied for it. But it was all around innovation, AI, access to care, and all those things. And those are things that kind of blow my mind. As like, there's money there. How do we do a better job of actually making people aware of it so that we can more rapidly deploy things like AI in healthcare? Because it's a game changer for certain, but you got to have the money to pay for it. And finding those opportunities is a big deal. And so we actually have a whole grant department that tries to fund those. Now, it's self-serving. We get to help implement it, so we get some of the money. But there's funds out there, but I would look at the state and more local level than I would necessarily at the Fed. I take the Fed money, but there's state as well.
And I think we've seen a shift because the premise is whether it's Medicare Advantage or the federal employee program, et cetera, is to drive to healthy outcomes for the member patient base. And as you see that shift, I think they're opening more to eliminate that bureaucracy from the system, which is what these AI solutions are enabling us to do. Even, and again, for the group, the federal employee program is run by the Blue Cross Blue Shield Association. Historically, they've been relatively slow to innovate. But you've seen in the past 2 years, it's been a pretty exponential curve on being open to make changes, open to use new tools and technology, because at the end of the day, they're really trying to improve the healthy outcomes and taking advantage of it, whether it's at a state or federal level, is what we have to do.
So that's the carrot approach. There's now the stick approach too. Unfortunately, it's come as predicted. So there are now medical legal suits on both sides to sue a health system for not using AI, which I predicted even last year. So that's here. A health system is getting sued for not using a tool, an AI tool for brain imaging, and a patient died from a stroke because of a delayed intervention. There are also now patients suing a doctor and his group for using AI and led to negative outcomes. So, which is hard to prove from an AI perspective because doctors ultimately have the final decision. So, but there are definitely legal suits now are happening on both sides. So that's the stick approach. And I think if you look at brain imaging, you're asking about clinical use, it's now, I think, in over 50% of hospitals will have an AI tool for brain imaging that may be news to you. It really got adopted fast. So I think the lesson I learned in the last decade is unless you have a very convincing use case, the adoption curve is very different. So you have to, once a gastroenterologist used AI for endoscopy, that subspecialty took off in terms of using AI. I can usually tell the interest level of a subspecialty by the size of the room I'm speaking in, right? So gastroenterology used to be a little breakout session with about 20 people. Now it's a keynote in a ballroom. So and it's going to happen with every subspecialty in every area. And something like generative AI and conversational AI is going to be for all the subspecialties. So that's the universal appeal of humans communicating with humans, which is what we're trying to enable better with artificial intelligence. So we're sort of close to closing time, right? Maybe a last takeaway from all of our panelists. We'll start with Greg this time.
I had an image of your provider outreach bot talking to my provider contact bot in a world where nobody actually talks to each other. No, I think the theme you heard from me is using these tools to build trust with your members and patients. And the tools are only as good as their, even using your text example, they trust the results because they know you're behind it. And so the more we can actually build our organizations to do both and do that convalescence, as you said, I think is going to be an important piece.
And for me on the provider side, there was the point about taking jobs away. I have several clients across the country. We're in probably 3/4 of the hospitals in the nation. Nobody has enough people, particularly for the administrative tasks. And so anywhere we can leverage AI to either improve the performance of the people we do have, so instead of doing 10, I can do 20 or whatever that might be, of higher quality, or replace those open spots that I still have patients coming in. I've still got to take calls and schedules and all those things, but I don't have any bodies to do it. We've got to spin up AI a lot faster than we already have to kind of fill those, because what we don't want is the clinical care to suffer, or delays, or okay, we'll schedule out a month because I can't get to you yet. So we've got to take care of that on our side. But that's a big fear of mine, is we can't process the patients fast enough to get them in the clinical care they need.
Yeah, so in my lens, it's like what iPhone had done in 2005, 2006 when it was put in front of people, and what Gen AI has done, right? So the possibilities, everybody has seen the possibilities. So as a business, if you're not going to implement, you'll become dinosaurs, right? It's just as simple as that. So AI as its own is going to be integrated part of everything that we do, right? What Greg said, I completely share that. Trust in healthcare, and healthcare is the slowest sector that moves along. But I think once the trust is built and there is human in the loop to begin with, as we mature this, the possibilities are endless, and it must happen. It's not even when will it happen, stuff like it's already happening, it will happen, and either you can be in the race or you can be out of the race. So, but a lot of possibilities, and especially to one thing that Dr. Chang had said about health and why it's different, because health is personal. My health is different than Dr. Chang's health, and how do we enable that so AI helps us to improve our lifespan, and that's the underlying thing that we want to achieve out of this.
Well, we're not too far from Cape Canaveral, so it reminds me of the space missions. As some of you old enough to remember, the Apollo landings, and now we're going back to the moon, I think in the next year or two, and heading to Mars in a decade. So and it's renewed because my daughter, who's 10, wants to be a NASA engineer. And I used to think, I'll dream along with you, until her teacher called me, and I thought it was something serious, but she said that she's in the 4th grade, that she's going to enter her into the 7th grade math competition nationally because she's that good at math. So I said, well, and I kept saying, my Emma is that good at math. So it just goes to show you that anything's possible, right? So Gene Kranz, who's the command center director when Apollo 13 happened, and I remember Apollo 13 when, for some of you who are young enough to not remember or not know, it was when there was an explosion in the command module, and the 3 astronauts it didn't look good for them to come back, and then people were saying on the news, we're unfortunately looking at 3 dead astronauts. People lost hope, except one person, that is the commander, and that's why he was the leader. And the president called him and said, this is going to be the worst moment for NASA. And then he said, without hesitation, no, with all due respect, this is going to be our best moment. So healthcare is having an Apollo 13 moment. This is the worst time in healthcare after the pandemic. We're actually still technically in it. When you talk to clinicians, you'll probably get a sense that this is the lowest morale that we've ever seen in healthcare. But I do think that with AI and other tools that are available, potentially this could be actually our best moment to come out of this nadir of healthcare and bring us an amazing 2 or 3 decades in healthcare. So I'm cautiously optimistic that if we all work together and all utilize the tools that are available, remember AI is here earlier than expected at this level. Even AI expert friends of mine say that. There's even a discussion that this is emergence, which is doing a lot more than technically possible with AI. So that's a little bit scary, but it is here in a big way, and shame on us if we don't take advantage of this technology to improve healthcare. So with that positive note, I'll give it back to Gary.
First of all, thank you to our distinguished panel. Amazing, great talk. Thank you very much. I don't know if anybody picked up on the prediction, and Dr. Chang is known for his predictions to come true. Anybody pick up on the personalized health, omics prediction of personalized health with pharma really making a difference in our lives? And AI is, that is just a perfect play. So thank you again, everybody. And thanks for joining us, and I hope you enjoy the conference.